Hey guys, I am Yogita Modi. We will discuss about the diuretics, how it is works. So firstly, we will discuss about the renal physiology, and then we can easily understand how the diuretics and antidiuretics exactly work on the renal tubules. So firstly, we will discuss what are the channels, what are the site where the drugs are act. This is the Henle loop. This is the DCT part, and this is collective tubes. So here we discuss that we are having this sites where the sodium is absorbed according to the gradient potential. Here the another transporter where the sodium and potassium transported in a symport way. Here we have another channel transporter where the sodium is transported with the hydrogen, and after that passively the chloride transportation and sodium transportation along with water. After that, we are having the Helner loop. Helner loop majorly absorbing the water, and here absorbing the electrolytes. So here we are having the another transporter named as sodium chloride potassium co-transporter. Here the all the three ion transported unidirectional, and along this the calcium and magnesium transported passively through the paracellular space. And site 3, sodium chloride symport. Here sodium chloride antiport. Okay, after that the chloride is passively transported, water is passively transported. Okay, and here we are having another one transporter named as sodium chloride transporter. Here the aldosterone mainly act. After classification of the diuretics. The classification of the diuretics depends upon where they are act. So we are having the inhibitor of sodium potassium chloride cotransporter. Then we are having the inhibitor of sodium chloride symport. After we are having the weak diuretics. So first we are having this type of the diuretics which are act on thick ascending loop of the Helene. This is act on the early distal tubule part. Okay, and this is act on the PCT part. This is act on the whole part of the nephron, and this is act on the distal part of the TCT. Okay, now come on the diuretics act on the distal part of the Helene loop. So it is also called as the loop diuretics, and the example are furosemide and torosemides. So we can easily remember the semide word. Diuretics work on the distal part of the nephron. It is divided into benzothiazines and thiazides like. So we are having example like hydrochlorothiazide, then benzthiazide, chlorthiazide, and then thiazide like we are having the chlorthylidone, zipamide, endopamide, and clopamide. So we can easily remember this palmade word. Okay. After that, we are having the carbonic anhydrase inhibitor, which is act on the PCT part. So the example is acetazolamide. After that, we are having the anti-nephron acting diuretics, also called as osmotic diuretics. The example is mannitol, glycerol, and we are having the potassium sparing diuretics, which is act on the distal part of the DCT. This is divided according to the way it is act on the renal epithelium sodium channel inhibitor, and this is aldosterone receptor. Now the example are spironolactone, and here the example are amiloride. Okay, these are the whole classification of diuretics. Now we individually describe about classes of the diuretics. So firstly we discuss about loop diuretics, which is also called as sodium, potassium, chloride, O, transporter. Okay. Now firstly we will discuss how the normal receptor act, and after how the drug are inhibit the receptor. So this is the lumen side, and this is the basolateral side. Okay. Now normally what happen here, the filtration are happen and filtrate coming here. Now the filtrate contains sodium, chloride, potassium and other nutrient, water and glucose and all. Here the transporter is called as sodium, potassium, chloride cotransporter, which is transported unidirectionally sodium, chloride and potassium. Here another one transporter which is called as the sodium potassium ATPs or sodium potassium transporter, which is transported sodium to the basolateral side, and here it is transported the potassium into the luminal side. Calcium, which is transported from the luminal side, which is now into the luminal cell. Now it is transported by the chloride channel into the interstitium. After that, calcium and magnesium passively transported by the paracellular space. Okay. Now we are having the drug which is called as the loop diuretics. The example is furosemide, which is inhibit this transporter and now inhibit all this transport ion, and now the sodium concentration is increasing, chloride concentration is increasing, and potassium concentration is also increasing. Here all these things are increasing along this. Calcium and magnesium also not transported by the paracellular because these are transported only for the balance of the potential. Okay, so we will write loop diuretics. The mechanism of the action will be blocking of sodium plus potassium plus 2 chloride co-transporter. The pharmacological action of the loop diuretics will be increasing sodium, chloride, potassium into urine along with calcium plus 2, magnesium plus 2. Okay, now come on use. This is used in cardiac, pulmonary, cerebral, and renal edema. Okay, and also used in hypercalcemia, hypermagnesemia, and used in hypertension and also during blood transfusion to reduce overload on heart. Okay, so what happened in this condition? Fluid is increasing in this condition, and now we want to discard this excessive fluid which is accumulated in the body. So the diuretics will excrete the fluid into urine. So it will reduce the edema. Then hyperkalemia and hypermagnesemia. In this condition, the calcium level in blood increasing and also magnesium level in blood increased. Now we want to discard this excess iron, so we'll use the diuretics, especially the loop diuretics, which is discard the excessive iron. Here we can see this, discard the excessive iron if they are inhibited by the furosemide. Then also used in reduce the hypertension. In hypertension, what we are seeing that the fluid is increased, the pressure is increased. So we want to reduce the pressure and BP. So we want to discard the excessive fluid or iron which is responsible for the attack the water. So we will use the diuretics to reduce the hypertension. After that we will use in the blood transfusion, increasing the load on the heart while transfusion of the blood. So the diuretics removing the excessive fluid into the urine, then overload on the heart will be reduced. Okay, so this is the action of the mechanism, pharmacological action, how it is, what they are doing with the body, and this is use. Now come on the adverse effect. Adverse effect, first we can see the electrolyte disturbance. Okay, what electrolyte disturbance? Calcium will be reduced, magnesium will be reduced, sodium will be reduced. Okay, then potassium will be reduced. After that, metabolic imbalance. In metabolic imbalance, what we can see, hyperglycemia, hypertension, uricinemia, hyperlipidemia. Along this, with only with low diuretics, we can see ototoxicity. What is ototoxicity? It causing the uh, deafness. How? In this condition, it increasing the salt contained in endolymph. Okay. Third, fourth, we are having the hypersensitivity, like hypersensitivity to the drugs. Now, drug interaction. Drug interaction, we are having the loop diuretics. If we are using with the lithium, it causing the lithium toxicity. If loop diuretics used with amiloride, it neutralizing the potassium depletion because the amiloride is a potassium sparing drug, right? And loop diuretic is excreted the potassium in the urine. So basically they are cancel out effect. After that loop diuretic act with the or it is used with the non-steroidal anti-inflammatory drugs. It causing the sodium plus water retention. Okay. Now discuss the second class of the diuretics called as inhibitor of sodium chloride symport transporter. Okay, this is divided into two categories as we know: benzothiazide and thiazide like. Okay, and how it is act. Normally, the sodium chloride symport transporter transported the sodium and chloride which is present in the lumen side transported into the basolateral side. Okay, here the basolateral membrane we are having another one transporter called as a sodium potassium ATPase. This is transported the sodium which is coming from the luminal side transported into the interstitium and chloride is also transported into the interstitium via the chloride channel. So thiazide act on here and inhibit this transport. Okay, so here the sodium is increasing, chloride is also increasing. By this, they are act as a diuretics. Now we discuss how it is identity mechanism of action. So this is blocking sodium chloride Symport, transporter. Along this, also decreasing the potassium and bicarbonate absorption. But this is increasing calcium plus 2 absorption via sodium, calcium plus 2 antipode transporter. Okay, because the thiazide where it is act, they are act on the distal tubule, but where the early part. Okay, now come on the uses. Again, this is used as the same edema, reduce the fluid. Okay, then hypertension, hypercalciuria. Okay, hypercalciuria and diabetes insipidus. Okay, now how it is used in hypercalciuria, it reducing the calcium plus 2 loss in urine. How we saw this act by this mechanism, and also reduce or also used in diabetes insipidus because this is decreasing positive free water. Okay, now come on the what is the adverse effect. Okay, adverse effect same as like sodium will be reduced in the blood, hyponatremia, hypomagnesemia, hypokalemia, and and hypercalcemia. Okay, after metabolic what we are having, glucose will be increased, lipid will be increased, uric acid will be increased. Okay, and also causing important in the male, so we call as erectile dysfunction and hypersensitivity, and also harmful in pregnancy. Okay, now come on the third class of the diuretics called as weak diuretics is carbonic anhydrase enzyme inhibitor. Carbonic anhydrase enzyme inhibitor. Before that, we will learn how the carbonic anhydrase is act. So, this is the basolateral side. This is the luminal side. Here, this is the PCT cell, and this is the cilia where they are absorbing the filtrate. Renal filtrate, we found sodium bicarbonate split into bicarbonate ion and sodium ion. Bicarbonate ion, okay, sodium ion transported into the PCT cell called as sodium hydrogen pump. Here the hydrogen act with the sodium bicarbonate with the presence of carbonic anhydrase enzyme and forming the carbonic acid, which is again highly unstable and split into CO2 and H2O. This is absorbed by the PCT. Here what happened, the sodium which is absorbed by this transporter again transported into the interstitium along with the bicarbonate. How the bicarbonate is formed, water and the CO2 transported into the PCT cell in the presence of carbonic anhydrase, it converted into carbonic acid, which is unstable split into hydrogen ion and bicarbonate ion. Bicarbonate ion used to transport the sodium into the interstitium and hydrogen ion transported into the luminal side along with against the sodium. Okay, so this is the carbonic anhydrase enzyme act for the forming of carbonic acid. Now we will discuss the how it is inhibit. So what happen? The carbonic anhydrase inhibitor act on the enzymes and reduce this process. Okay. So here the accumulating the bicarbonate. Here they are accumulating H plus and accumulating sodium plus. Okay. Mechanism of the action. It inhibit carbonic anhydrase enzyme. So carbonic acid doesn't form. Okay. Then what are the pharmacological action? It increasing the sodium concentration, bicarbonate concentration, potassium concentration in the urine. Okay, so basically it is used in the alkaline urine. Okay, now discuss what is the use of the carbonic anhydrase inhibitor as a diuretics. So it is a weak diuretic, so we can use in the glaucoma, alkalization of the urine in acidic drug poisoning. Okay, and also used in the epilepsy and acute mountain sickness. Okay, now what are the adverse effects? Adverse effect will be hypokalemia, metabolic acidosis. Why metabolic acidosis? Because H concentration increasing in basolateral site, interstitium or cell. Okay. Third, hypersensitivity. Fourth, it causing the renal stone, responsible for the renal stone. And the carbonic anhydrase inhibitor is a contraindication in COPD, यानी कि chronic obstructive pulmonary disease and liver disease. Second subtype of the weak diuretic, osmotic diuretics. So the mechanism of the action of this osmotic diuretics will be drain water from tissue and increasing water loss. Okay, then we discuss the use. It is used in the intracranial pressure, intraocular pressure, then acute shutdown of renal system in shock, then use in maintain of electrolytes after dialysis. Okay, then adverse effect. Adverse effect will be pulmonary edema because this is attracting the water, so the water will be increasing the alveolar space, so it causing the pulmonary edema. Hyperglycemia. Okay, now this is a contraindication in congested heart failure, pulmonary edema, intracranial bleeding. Okay, the third subtype of the weak diuretics called as potassium sparing diuretics. Firstly, we discuss how the normally receptor act. Here we are having the aldosterone and this is the basolateral side. This is the luminal side. Okay. Aldosterone act on the aldosterone receptor and also bind with the mineralocorticoid receptor and forming the mineralocorticoid receptor aldosterone complex. This complex is transported into the nucleus and forming the mRNA. This mRNA will be directly this mRNA directly form the AIP. AIP is a aldosterone induced protein. This is responsible for the activity of this transporter and also increasing the ATP, which is used for the active transportation of the ions. Okay, so the AIP act on the sodium potassium transporter and epithelial sodium channel and also sodium potassium transporter. Okay, normally this is receptor how it is act, and now we are having the potassium sparing diuretics. First we are having the aldosterone antagonist, and second we are having the renal epithelium sodium channel inhibitor called as the amiloride. And so the spironolactone inhibit the formation of the this complex and inhibit the transportation to the nucleus and inhibit the formation of the mRNA. Amiloride is inhibit the epithelial sodium channel, which is responsible for the transportation of the sodium. Okay, now we will write the mechanism of the action. It's bind to mineralocorticoid receptor, aldosterone complex, and inhibit the formation of aldosterone induced protein. Okay, and amiloride act on the epithelium sodium. Okay, then use. This is used in the edema, congested heart failure, because we want potassium for the cardiac activity. Depletion of the potassium causes arrhythmias. Then use in Crohn's disease. Okay, then here are the adverse effect. Adverse effect will be hyperkalemia, peptic ulcer, and reproductive dysfunction. This is called in male erectile dysfunction, gynecomastia, and in female we are having the irregular menstrual cycle, menstrual activities, and tenderness and hardening of breast. Okay, so diuretic resistance. What is the diuretic resistance? This the prolonged use of the diuretics causes resistance to this type of the diuretics on the kidney. So this kind of the diuretics doesn't act on the kidney and doesn't work as we need. So Diuretic resistance prolonged use of diuretics, mainly what? Loop diuretics and thiazides. Okay, and commonly this is seen in elderly person or patient because they have a reduced GFR, reduce the renal blood flow, so the diuretics doesn't act or doesn't act or doesn't reach to site where they have to act. And in other condition, the diuretic resistance we can see in renal failure as earlier and heart failure because reducing the blood flow BP all to the kidney, liver liver disease. Okay, so how we will reduce this resistance? First, first we should increase the dose and frequency, but it will be harmful for the patient. Okay. Second, we can use this before meal. Okay. Third is reduce salt intake. Okay. Now collectively we will study or remind what are the complications in the using of the diuretics. First we are having the electrolyte imbalance. What are sodium will be decreasing in the blood, calcium will be decreasing, but exception increasing in thiazides. What kind of the transporter inhibitor? Sodium chloride sympod. Okay. Magnesium will be reduced in the blood. Chloride will be reduced in the blood. Potassium will be reduced in the blood, but increasing in the blood using of increasing in the blood using of potassium sparing diuretics. Okay. The second subclass of the weak diuretics. After that, it causing the alkaline urine because secreting the bicarbonate, excreting the bicarbonate. Okay. Second is metabolic disturbance. What are the metabolic disturbance? glucose will be increased, lipid will be increased, hyperuricemia. Okay. Then third, it causing the reproductive dysfunctions, erectile dysfunction, gynecomastia, erectile dysfunction, gynecomastia, and in female, breast hardening, tenderness, what other? Menstrual irregularity. Menstrual irregularity. And other is for the loop diuretics. We are having the oncotoxicity, 5, dizziness, headache in carbonic anhydrase inhibitor. 6 is muscle spasm because we don't have the sodium. Okay, these are the complication using of the diuretics.